University of Southern California. She also did a fellowship in Physicians for Reproductive Health at the Leadership Training Academy in New York, New York. Dr. Patel is a clinical professor of obstetrics and gynecology at the University of California at Irvine. She is also the Women's Health Medical Director at the Anaheim Federally Qualified Health Center and the Consulting Director of Vasectomy at Planned Parenthood of Orange and San Bernardino counties. Dr. Patel, we're so appreciative since you're in California, meaning it's 5 a.m. there. We are so appreciative that you're willing to give us this talk.
Well, thank you very much. I'm very happy to be here. And I'm actually originally a New Yorker, so I have lots of friends and family that have gone to Rutgers. So it's nice to kind of virtually at least be on the East Coast with you all. So good morning, everybody. Today we're going to talk about male contraception for OBGYNs and what you need to know to help your patients and their partners. And so to start off, I just wanted to relate that I do not have any financial disclosures. And for the purpose of this talk, when we talk about men or male, we're referring to people with penises, and women and female refer to people with vaginas. We do recognize that not all men have penises and not all people who have penises identify as men, but for the purpose of this talk, we'll use those terms. And so to go over our objectives today, we're going to list all the male contraceptive methods. We're going to describe their mechanism of action, their efficacy, their correct use, any advantages or disadvantages they may have, as well as what is our role as OBGYNs in counseling on male contraception, as well as apply this knowledge to hopefully your current practice. So just to start off, I'm an OBGYN just like most of you, and I primarily see female patients. But what I've realized is that though men impact the health of my female patients directly and indirectly, and so sexual and reproductive health involves men and women and is not just a woman's issue. So in order to achieve true gender equity and accountability, we have to engage men in reproductive health. After all, our patients trust their partners, and by engaging them, we're better helping our patients. So if not us as OBGYNs, then who? Who's going to take care of sexual and reproductive health for men? STD clinics are very limited in their scope. Urologists focus primarily on the urinary symptom, and some are interested in sexual and reproductive health. Primary care doctors also treat men, but they too are limited in their training on sexual and reproductive health. So there's not really a good OBGYN analog for men. This is why we as OBGYNs also need to be knowledgeable about male contraception. There's also a danger to neglecting men and their role in sexual and reproductive health. And so this study shows that with our current mindset, where women are primarily given the responsibility for contraception, men are reluctant to discuss contraception. And so we need to try to change this narrative and include men in our conversations, especially when they're present in the counseling room. Because having both partners be active in preventing pregnancy is going to be more efficacious. These global health studies also show that couples counseling and male engagement helps to increase the use of contraceptives, as well as increase communication among partners to ultimately improve family planning outcomes. Therefore, we as OBGYNs should know about male methods so we can teach our patients and their partners. We can help prevent our patients' unintended pregnancies. We can promote shared reproductive responsibility among men and women, and then either prescribe or be able to refer for male contraception. So let's start off by talking about the available barrier methods. If we have some time, we can talk about some hormonal methods, or we may have to save that for another time. So first, we're going to talk about male condoms, and here's a creative ad from Brazil for condom use. So condoms prevent pregnancy by blocking the passage of semen. It prevents infections by covering the major portals of entry and exit for many STIs. However, obviously they do not cover everything, so some STIs can still be shared with condom use. A sheath worn over the penis can be traced as far back as 1350 BC, where Egyptian men wore decorative covers for their penises, such as this one pictured. In 1564, Fallopius first described linen sheaths used to protect against syphilis. Protective sheaths were made from dried animal intestines in the 18th century, where, according to some sources, it was first given the name condom, presumably from the inventor Colonel Condom. Lastly, the advent of vulcanized rubber in 1843 led to the mass production of condoms made from natural rubber latex. Latex condoms are the most widely available and commonly used in the US. Use in adolescents actually peaked in 2003 to 63% in response to the HIV and STI epidemics, but has gradually declined since then. 20% of women currently use condoms for pregnancy and STI prevention, while 13% use condoms for pregnancy alone as their most effective method. When patients use condoms correctly and consistently, meaning every single time and apply it correctly, their risk of pregnancy is 2% in that first year. Given that patients do not always use condoms correctly or consistently with every act, real world use reflects a pregnancy rate of about 13% in the first year. Interestingly, every condom is tested for leakage, strength, dimensional requirements, package integrity, and if any fail, the entire lot is destroyed. So imported condoms must also comply with these strict requirements. And according to studies, condoms break approximately only 2% of the time, with another 2% that slip off completely. And many venture to say that it's due to incorrect sizing that condoms either break or slip off. Most condoms are 18 centimeters long and, 18 millimeters long. Or no, sorry, 18 centimeters long, that's correct. And a 5.2 centimeters wide, with the Trojan Magnums being 20 centimeters long and 5.4 centimeters wide. However, there is a condom company that you may not have heard of called My One Condoms that claims that these sizes only fit about 12% of users. So therefore, this company makes 10 different lengths, 9 widths for a total of 60 different sizes. And the website does have instructions on how users can measure and order their correct size. So there's no more excuses that the condoms don't fit. Male condoms are available in a variety of shapes, sizes, colors, and thicknesses, as well as with or without lubricants or spermicides, with or without reservoir tips or nipple ends. Condoms can be straight-sided or tapered towards the closed end, textured or ribbed or smooth, solid-colored, nearly transparent, odorless, scented, or flavored. The most popular are latex with natural membrane and synthetic, available for those with latex allergies. However, natural membrane condoms do not protect against sexually transmitted infections due to their small pores. And synthetic assumes STI prevention, but has not been extensively studied. So one must make sure that you're also using the correct lubrication for their condoms, specifically water or silicone-based for latex condoms. So in terms of advantages and disadvantages, the condom helps to protect against sexually transmitted infections, especially if you're using a latex or synthetic condom. It's accessible, it's overall affordable, it's usually easily attainable, it's portable, you can have it pretty much at any time, and it has minimal side effects overall. But in terms of disadvantages, you can have reduced sensation during intimacy. You could have a lack of spontaneity. You have to do something before every act of intercourse. You also must use it for the entire act of intercourse. It doesn't work. It's not used correctly if you take it off in the middle. Some men may have problems with erection given the delayed sensation. Some may be embarrassed or feel like their partner may not be able to trust them if they're asking to use a condom during that act. There also is the risk of lack of male cooperation. And so while California became one of the first states to outlaw stealthing, which is a slang term used for non-consensual removal of a condom during sex, New Jersey actually quickly followed suit with a similar bill, A2338. So now stealthing is actually criminalized in New Jersey. Other disadvantages include a latex allergy or sensitivity. And while only 6% of the US population has an allergy or insensitivity, it's higher among healthcare workers, which is about 8 to 12%. So how do you use a condom correctly? Well, one, you have to use it every single time. You have to use it for the entire duration of intercourse. And you want to make sure you open the package very carefully to avoid damage, meaning like opening it with your teeth is probably not a good idea because you could damage the condom itself. You want to make sure you pinch the tip before you roll down. You want to not double up on condoms, meaning not use a female and a male or two male, aka external or internal, or two externals together. You want to use the correct lubricant for the type of condom that you have. You want to make sure that when you remove the penis after ejaculation, you hold the condom at its base and check for any damages or holds, holding it up to the light before you throw it out. You also want to make sure that patients that are using any vaginal medications, like for yeast infections or boric acid, that have oil-based ingredients, don't use latex condoms, or potentially, use another form of birth control during that time, or use synthetic condoms, because the medications can affect the integrity of the latex. You also want to make sure that you're storing the condoms in a cool and dry place out of direct sunlight, because excessive heat will weaken the latex. And it can be stored in a wallet, but really only for 1 month of use when it's kept away from heat and sunlight. So you want to check for expiration dates, but also not keep condoms in wallets or other storage areas for too long, given that they do expire and they can become weakened. So we can't just give away condoms and expect for them to be enough. We actually need to engage the male partner in their use. So this study found that rushed condom application led to higher rates of breakage and slippage. And so when you have that patient in the room with their partner explaining how to use it and kind of the most important aspects of it, aka that you want to make sure that they feel comfortable using it, they're able to negotiate it, and actually practice even with your patient in terms of how to ask their partner to use it, or make sure that they take their time putting it on. So our role as OBGYNs is not just to ask if condoms are being used, but also how often, right? Because, people might not be using it with every act, as well as assess barriers to use that may benefit our patients. So for example, do they have issues with talking to their partner about condom use, and maybe role play with your patient of how you can provide responses if the partner objects. You can also provide condoms at no cost and make sure they have extra available. You can also provide advanced prescriptions of emergency contraception. So just in case they forget to use it or the condom breaks, they have something on hand that they can use to prevent pregnancy. You can also talk about how condoms protect future fertility through infection prevention. You can also, while you're in your office and doing potentially an ultrasound, show them how to put a condom on the ultrasound probe and use that as a model or something similarly shaped. And that's a great way to kind of incorporate, just while you're putting the probe on, going over condom usage. So we've talked a little bit about condoms. Our next method we're going to talk about is withdrawal, also known as pulling out, coitus interruptus, or pull and pray. So withdrawal is the practice of removing the penis from the vagina and away from the external genitalia of the woman before ejaculation, specifically to avoid pregnancy. And it inhibits fertilization by preventing contact between sperm and egg. It's actually dated back to the Bible in Genesis, where Judah commanded his son to sleep with his brother's wife, but instead he spilled his semen on the ground and therefore withdrew to refuse to impregnate his brother's widow. And this method was probably widely practiced throughout history and has actually played a role in fertility declines prior to the advent of the oral contraceptive pill. So you may be surprised to learn that 65% of reproductive age women have ever used withdrawal in their lives for birth control. And it may surprise you just that it's been so many people that have ever tried it ever before. And withdrawal rates are actually increasing according to the National Survey of Family Growth, from 3.6% of reproductive age women to 7.1% in 2015. As a reminder, the National Survey of Family Growth usually lists the most effective method a user is using. So when we think about how many people are using withdrawal with another method or dual use, this actually increases to 14.6% in 2014. So unless we're specifically asking about all the methods that the patient is using, we may not actually get a true history of what's going on. So who uses withdrawal? And so you may be surprised to learn that According to studies, people in the highest income bracket actually use withdrawal more often. If they're born outside the United States, they use it more often. If they're cohabitating with their partner, if they have at least a high school level education, or if they're expecting 1 to 2 children in the future. Other studies show that withdrawal use was higher for never married men compared to formerly married or cohabitating men. Women who would be pleased about a pregnancy, or alternatively, sorry, I have a furry friend, those who would be want to I can't say that, eroticize safety, were more likely to use withdrawal, as well as men who have difficulty using condoms and want to enhance pleasure or intimacy, especially compared to using condoms. So there's many ways that women and couples can use withdrawal. And so that can be by itself as the sole contraceptive method. It could be in combination with another method. And in actuality, that those people may be more vigilant to prevent pregnancy rather than what you would think of people using withdrawal as less vigilant. Or they can use it in a rotating fashion where, like, if they don't have a condom on hand, they use withdrawal, but otherwise they generally use condoms. And so there can be lots of reasons. So, if you have nothing, this is definitely better than nothing. It can be extra insurance against pregnancy. It can enhance sexual pleasure. It might be kind of part of the intimacy and pleasure that the couple derives. And some people actually have a seminal protein allergy. And so that could help prevent an allergic reaction for the woman. So in terms of advantages and disadvantages, there's no cost. There's no interaction with a healthcare provider in order to use withdrawal use. It's all natural. There's no adverse health outcomes. While psychiatrists thought that withdrawal would cause issues with men in the future, it is not true, and studies have disproven that. It's always available. You always have it to use. It does involve male involvement in contraception. And it can always be used as a backup method when there's nothing else available, or can enhance the effectiveness of current methods that are being used. The disadvantages involve that it does interrupt coitus. So you may have an interruption in incitement or the plateau phase. However, studies haven't necessarily shown that. The male partner may also lack self-control that is demanded by this method for every active intercourse, and those with premature ejaculation may have more of an issue with this. And then some people may feel anxiety and kind of relinquishing control over contraception towards this method that is very behavioral and could very much be influenced by a man's ability to withdraw on time. So how effective is pulling out or withdrawal? And so according to the NSFG, the typical failure rate is about 20% if you're using it only for birth control. Just to review, not using any contraceptive method, the pregnancy rate is 85%. And for condoms, your pregnancy rate with typical use, so inconsistent or incorrect use at times, is 13%. For perfect use, there have been no controlled studies that have actually said what is, if you're using it correctly and consistently every single time, the rate of pregnancy. But an educated guess is that it's about 4%. And that's related to potentially having sperm present in pre-ejaculate. And so what other factors could be related to failure of withdrawal? So some things to talk to patients about is, like, maybe withdrawal is not going to be the best when you guys have gone out clubbing and have been drinking, because, not being fully cognitively there might impair your ability to pull out on time. Or are you able to are you in a position during intercourse to pull out? So if, like, the woman is on top, it would be more difficult for a man to pull out on time. And so maybe that's not a great position for, like, the end of intercourse. So there's lots of different kind of factors that are related to failure of withdrawal. But the pre-ejaculate, or the presence and concentration of sperm in this fluid that comes out prior to ejaculation, is kind of the concern of what perfect use of every time pulling out on time could still cause pregnancy. So what is pre-ejaculate? Pre-ejaculate is a lubricating secretion. It's produced by the Littre's and Cowper's glands in the male reproductive system that helps to kind of clear out the acidity of the the urine that was present in the male urethra prior to the sperm coming through, to be able to like provide more of a better environment for that sperm to come through the male urethra. However, if there is, sperm present in the male urethra, that pre-ejaculate could potentially pick it up. But by definition, this pre-ejaculate itself shouldn't contain sperm, right? Because it's coming from these glands versus upstream the testicles itself. However, as you can see from these previous studies investigating sperm and pre-ejaculate that used various methods, and some had contradictory findings, where some found sperm present when they looked at pre-ejaculate, and this is all pre-ejaculate that was collected through masturbation, and some didn't, and some did. And one of the most rigorous studies implied that some men do have sperm in their pre-ejaculate and some men do not. And maybe there's some sort of leakage of sperm. The other thing that they also found was that some men consistently had it and some men didn't. However, this has not been tested before. So actually, my research project involved collecting pre-ejaculate on multiple occasions from different couples and trying to figure out if there was consistently sperm present and consistently sperm absent, and who actually was more likely to have sperm present or absent. And this information could help us learn, who that uses withdrawal is more likely to have a failure versus who is not. Because I know, at least in my personal life, I've heard from even my friends in medical school that have used withdrawal for their contraceptive method for their lives and only had pregnancies when they plan to have pregnancies, versus I know also patients that have used withdrawal and even friends and had accidents in a sense. So why is it that some people can use it effectively and some people can't? And is there even with correct and consistent use, some factors that could influence this? So basically what I found was that 26.1% of the men that I had studied had sperm present in their pre-ejaculate. And this was not necessarily consistent in all of their samples, but 73.9% had no sperm in any of their samples, right? I also found that when you dry pre-ejaculate, it comes out in this pretty fern-like pattern, which is very similar to amniotic fluid. And what I found is that when it comes out in this pattern, which is, the true pre-ejaculate, so pre-ejaculate from the Capillary and Littre's glands, it does not contain sperm, right? Which by definition makes sense. However, when you have other upstream fluids that are, entering the pre-ejaculate, like prostatic fluid, you may also then get sperm because there is no actual valve in the male reproductive system. And so ejaculatory continence might be by the angle of insertion, and maybe kind of more behavioral of men when they withdraw versus when they don't. So that was really interesting to find. We also found that men that were married or men that had a history of sexually transmitted infections were more likely to have sperm in pre-ejaculate. And so we obviously need a bigger study to verify this, but interestingly, men that are married may have, more security in the relationship and maybe withdrawing at a later time. We also could see some plausibility with men with a history of sexually transmitted infections may have had some damage to their reproductive system where they're not able to kind of control their continence of semen. And so these are some just interesting findings I wanted to share with you all. But yeah. So in terms of how do you use withdrawal correctly? So again, this is a behavioral method. And so another thing in my study that I found was that when men edge or kind of get to the point of ejaculation and then hold back, they actually release some sperm into their pre-ejaculate. And so that behavior could very much lead to patients then having failures of this contraceptive method because of the fact that more sperm is able to actually enter the pre-ejaculate. So one, not doing that would probably increase your efficacy of the method, but also you want to make sure you withdraw the penis when you're feeling that sensation to ejaculate. And honestly, the earlier the better, so as people, do it at different stages of when they feel that sensation. You want to make sure that you're directing the ejaculate away from your partner's genitalia. You want to make sure that you're refraining from factors that can impair your ability to withdraw in time. So those things like dirt and positioning or alcohol or other type of drug use. Also, if there's going to be more than one active intercourse that takes place in a relatively short period of time, urinating and wiping off the tip of the penis before intercourse is recommended to kind of clear away any sperm from a previous ejaculation that's still present in the urethra. And then it's really important to communicate with your partner of the risk of pulling out too late with each act. So really, like the partners should be talking to each other like, hey, do you think you pulled out at a reasonable time prior to ejaculation? Or, should I be taking some emergency contraception right now because there's a possibility you pulled out too late? So this is definitely something that we as OBGYNs can be involved in with our patients to help them feel empowered to talk to their partners if they are using this. So one thing to keep in mind is that a lot more people are using withdrawal than you think. Like when I first started learning about this and researching this, I was so surprised that when I asked a patient and they said, oh, they're not using anything for birth control, I now learned to ask them, oh, are you, pulling out or using withdrawal? And then oh yeah, we're doing that. But they don't consider it a birth control method. So they don't necessarily will bring it up to you. But when you specifically ask about it, you'll be surprised to learn how many people are actually using it. And so if they are, you want to be able to counsel them to the best that we have knowledge about withdrawal. So patients may not be reporting this when you first ask them about birth control methods. You can also talk to them about, because realistically, some patients are not going to necessarily, use a pill and use it every single day or use an IUD. And so how do you kind of meet them where they are? And so one of those ways is, talking to them like, hey, if you really want to prevent pregnancy, withdrawal is going to be better than not using anything. You can use it with another contraceptive method to increase efficacy, because what if that patient is not choosing the method that you think would be the most efficacious for them? They can use multiple methods and that would help even more. Or let's say they forget to, take their pill that day or, use a condom and they have nothing else available and they're going to have intercourse. Well, then, at least they can use withdrawal to help prevent a pregnancy during that act. You do want to also inform them that some individuals may have sperm in their pre-ejaculate. And so it's smart to kind of to withdraw prior to, feeling any sensation of ejaculation in order to guarantee that there is the least amount of sperm present in that pre-ejaculate. You also want to counsel that withdrawal is not necessarily effective against sexually transmitted infections. As you saw from our previous studies, there were HIV particles in pre-ejaculate. And then you also want to provide a route of open communication and help the patient talk to their partner about correct use, as well as potentially provide some advanced emergency contraception in case the partner did pull out too late. All right, so to move on to our last available method of male contraception, we're going to talk about vasectomy, which is the form of male permanent contraception similar to tubal ligations for women. And so what a vasectomy does is it's the surgical severance or occlusion of the vas deferens, and it creates a mechanical obstruction for the passage of sperm during ejaculation. So there's physically, no way for the sperm to kind of jump this gap. And so given that sperm are produced throughout a man's lifetime, one vasectomy is lifelong contraception versus a tubal is only really necessary until menopause. So what is kind of the use of vasectomy? And to be honest, very few women rely on vasectomy in the US. So it's about 4.5%, and that's compared to 13.4% of women that rely on tubal ligation. And so who is more likely to get a vasectomy? And so what the studies have shown is that non-Hispanic white men are more likely to have a vasectomy if you have higher education and income, which is actually inversely related to who gets tubals. People with lower education and lower income more likely to have a tubal ligation, as well as those who have private insurance. And so Medicaid pays for 40% of tubal ligations, but only 0.05% of vasectomies. And you might wonder, like, why do we see these things? Like, why does this occur? And so some reasons for underutilization of vasectomy may be a lack of awareness, who is talking to these men about vasectomy? Is it their doctors that they don't go to because they don't get sick or are afraid of the doctor? Or is it their partners that maybe don't know about it either to talk to them about it? So these are kind of places where we can definitely help. They may have misconceptions. So I provide vasectomies, and some of my patients walk in thinking they're getting castrated. They're thinking they're getting neutered just like a dog is, and not realizing that a vasectomy is just cutting the tubes and there's no difference in their hormones afterwards. But I'm surprised they walk into my office thinking that and they're still there. But that could lead to a lot of people not wanting to even walk in my office the first time. There's also a lack of access. There's some vasectomy deserts across the country where like there is no trained provider to provide this. And so, especially for people that can't afford to pay for it or travel, they're less likely to get it. There's also some like provider bias that, family planning is a woman's responsibility. So why do we need to provide funding or provide services for men? And then the other issue is that some insurances do not cover vasectomy without cost sharing. And so that could be financially difficult for men to participate. And something for you to know is that the ACA, while it required no out of pocket or no cost sharing for any contraceptives, those were only female contraceptives. So for vasectomies, it did not require no cost sharing. So some insurances could still provide or could still require cost sharing, which would potentially inhibit some men from pursuing that option. So the other thing to think about in terms of associations with vasectomy is that it is way safer than getting a tubal ligation. When you're going to the scrotum, you don't need to be under general anesthesia. You don't need to, have a whole OR setup, and you're not at risk of injuring any other organs or having anesthesia risk as you would be with a tubal ligation. So a vasectomy is actually 20 times safer. And tubal ligation has a 12% higher mortality rate than vasectomy. The other issue is because you don't need all those things, the cost effectiveness for vasectomy is way higher, with in 2012 average costs being $700 for a vasectomy versus $2,900. For a tubal, that's probably pretty cheap, to be honest, given all like OR costs and everything like that. But for a vasectomy, I think we're down to like $450 or $500 for a vasectomy now. So that does vary across states as well as different institutions. And so we kind of talked about how there's kind of a low utilization as well as a low prevalence of vasectomy. However, that is changing. One of the unforeseen consequences of the Dobbs decision was actually an increase in interest in vasectomy, especially in states where trigger bans have been enacted. And so some authors from urology departments across the Midwest did demonstrate that Google searches for vasectomy has increased in the 2 weeks following the Dobbs decision compared to previous trends, as well as did during the leak from the Supreme Court decision 2 months prior. And so these search trends are also variable to which states specifically have trigger bans that were enacted. And so this is interesting because the prevalence of vasectomy may actually be increasing because of changing laws. So what do we need to know about efficacy? Now, the perfect use failure rate, and so by perfect use, we mean that the vasectomy was done and then the patient went for a post-vasectomy semen analysis 2 to 4 months later, and that semen analysis showed either no more sperm at all or rare non-motile sperm, which we'll go over in a little bit. The rate of pregnancy with those factors is only 0.05%. So if that sounds familiar to you, that's about what the efficacy of an Nexplanon is in 1 year. And so that's really, really effective. That's one of our most effective methods. The typical use failure rate is about 0.15%. So still very, very effective, kind of the same as IUDs. And that's if patients did not go for their PVSA. So we're not entirely sure if all of them had donor sperm after their vasectomy. So if sperm is still present on a PVSA 6 months after their vasectomy, that's considered to be a failure of the vasectomy. Either, surgically things did not heal properly, or there was an early recanalization and may require a repeat procedure. But that's necessary in less than 1% of vasectomies, luckily. There is a possibility that recanalization can occur years later, just like, how some people still get pregnant after a tubal, because just, life is strong in terms of wanting to procreate. So that can happen. But overall, the risk of pregnancy after a vasectomy is very, very low. So some considerations you may want to have as a provider when you are doing your history for the male partner as well as your physical, you want to make sure you know about any bleeding disorders. Having a bleeding disorder or being on anticoagulation is not necessarily a contraindication because of the so little amount of blood loss that you have with this procedure, but could increase the risk of bleeding and hematoma. So something you do want to talk to patients about. You do want to do an exam to make sure there is no testicular tumor, like a hard mass on their testicle, because you could see that tumor if you are operating on the scrotum. You also want to make sure there's no undescended testicles, because that would also be a contraindication. You want to, during your exam, assess patients' comfort with local anesthesia during your exam and seeing how uncomfortable they are with just doing an exam. You also want to check for varicocele, which is like that bag of worms or blood vessels around the spermatic cord, as well as the hydrocele, which is like a water balloon around the spermatic cord. These are not contraindications to doing the procedure, but could make it a little bit more difficult. Really, if you can feel the vas and the vas feels kind of like an al dente pasta noodle, you're able to do a vasectomy. The other thing to keep in mind is to be able to counsel your patients that vasectomy is not a risk factor for any of these other things that they may have heard about. So you're not increased of a chance to get prostate cancer or heart disease or stroke or dementia or testicular cancer from having a vasectomy. So in terms of how do you do a vasectomy? So the first thing that you want to do is to isolate the vas. And so the vas deferens is kind of the equivalent to the fallopian tubes. And so that's what we're actually surgically obstructing in order to prevent sperm passage. And so just to review, hormones do not pass through the spermatic cord. So hormones are absorbed through the bloodstream. And so that is not affected by doing a vasectomy. And so the different ways to isolate a vas, a conventional vasectomy is, making a big incision on the scrotum in order to find the vas. But what's recommended is doing a minimally invasive approach with a less than a 1 centimeter incision, and optimally a no scalpel vasectomy where you're not using a scalpel, but I'll show you exactly how you can still access all of the things that you need to access. And so this is more related, the isolation technique, to pain or bleeding or infection. And then occlusion of the vas. So how are you actually cutting or tying or clipping or, separating the two ends of the vas is more related to the success and failure of the vasectomy itself and whether sperm are still present in your semen analysis after. So in order to start off your procedure, you want to give the patient local anesthesia. And so in recent years, this no needle vasectomy has been advertised to help reduce pain during the procedure. So instead of a 25 or 27 gauge needle with anesthetic making this huge bubble of anesthesia at the spermatic cord, this is called a MATA jet or a MATA injector. And what it is a high pressure pneumatic spray that with each spray, it's only 0.1 cc of anesthesia, but it actually penetrates the skin as well as the perivasal tissues. And honestly, I only do like 3 sprays on each vas at my incision site. So maybe 0.6 cc's of anesthesia, and the patient is completely numb. Like, it is incredible how you can use this to anesthetize a patient where they don't feel any pain. They still feel pressure, pulling, tugging, that's all normal, but no pain. So then you use, similar to a Babcock clamp, but it's called a vasectomy clamp, this little mini clamp, to isolate the vas over the skin and over the tissues. You then use your dissecting forceps instead of a scalpel to separate the fibers of the skin and of the fascia in order to expose the vas. And then you supinate your wrist and you get the vas exposed right here. And so it usually is very white, kind of feels like a al dente noodle. You then separate the vas from the vasal vessels that are underneath it. And then there's different occlusion techniques that you can use. The preferred techniques that produce the most efficacy are mucosal cautery. So you actually put a needle cautery tip inside each side of the vas here, and then do fascial interposition, or just leave it without fascial interposition, or cauterize. So they don't recommend suturing and clipping anymore. And so what fascial interposition is placing a layer of the vasal sheath between the two ends of the vas. And so you're basically kind of creating, you're putting the two ends in two different layers of the scrotal tissue, so that your testicular end is sticking out and your abdominal end is hidden behind here. And so what they found is that that actually decreases the time to azoospermia, because now if the sperm are in two different layers coming out, they can't, swim to the other side of the vas deferens. And there's reduced failures based on semen analysis when you do fascial interposition, so that is recommended. When we talk about complications, bleeding, including hematoma, is, as well as infection, is some of the most common, and that's only at 1 to 2%. So overall, a very safe procedure. We don't need routine antibiotics for this type of procedure. However, patients with diabetes or at risk for infection may benefit from some. And then chronic scrotal pain associated with a negative impact on quality of life is very, very rare as well, but could be a complication. And so what that is persistent or unilateral or bilateral pain. Poor quality studies have been done about this, but they say in the most robust study that it was about 0.9% at 7 months post-op. And usually it's only very severe where it interferes with quality of life in 1 to 2% of men. Medical or surgical therapy can be, but is not always effective for this. In terms of long-term post-op complications, some patients can develop epididymitis, so swelling, inflammation, and infection of their epididymis, but a true bacterial epididymitis is estimated in only 1.5%. More commonly, which also is kind of inconsequential, is developing a sperm granuloma. So it's really just a little collection of sperm because they have nowhere else to go. Eventually, when the body realizes that they have nowhere else to go, that pressure buildup does create less sperm production in the testicle. And so that does reduce kind of that sperm granuloma. You can also kind of use, if you're having pain from it, NSAIDs or analgesics. You can also massage it, and that helps to kind of let it absorb and go away on its own. In terms of some expectations for postoperatively, you want to make sure the man is wearing a supportive undergarment or like a jock strap, essentially, to help relieve tension on the scrotum. Having some mild swelling and pain is very common. Putting cold packs or frozen peas is very common as well. Keeping the incision clean and dry, not doing any physical work, and or any strenuous exercise is recommended, so that way you don't increase your chance of bleeding and hematoma. You want to refrain from ejaculation for at least 1 week, and then it's really, really important to use another form of birth control because, again, vasectomies are not immediately effective like tubal ligations are. So you do want to make sure until you get that post-vasectomy semen analysis that another form of birth control is being used. And then it is normal to have some blood in the ejaculate, which will resolve over time as everything heals. So how to use this correctly? Well, one, you have to show up for your appointment in order to use vasectomy as your contraceptive method. I've been, I used to have a really high no-show rate, and now honestly, everybody shows up for their vasectomy. So I don't know what is changing, but people are more and more wanting to be involved in male reproductive responsibility, which is great. So it's not effective unless you don't get it done. You also, in that 2 to 4 months after the procedure, do want to get a semen analysis to confirm that there is no more sperm. And so success of a vasectomy is considered no sperm at all on your semen analysis. You're still going to have ejaculate, it's still going to be fluids that come out. It's going to look like normal ejaculate, but it just won't have sperm in it. Or having what's called rare non-motile sperm, which is less than or equal to 100,000 of a non-motile sperm in the specimen. The FDA actually did clear this at-home test called sperm check vasectomy that allows patients to check for this at home to try to increase compliance with the PVSA, because in general, people don't usually come back for their post-vasectomy semen analysis, which is why a lot of people have that 0.15% chance of pregnancy in the first year. So in terms of advantages and disadvantages, the vasectomy provides permanent, lifelong contraception. It's highly effective. There's low risk surgical complications overall. Tubules are way riskier. There's a quick recovery. It's cost effective. There's no interruption in intercourse, and it's private. There is potentially a waiting period if the patient has federally insured federal insurance, as there is for women. It does require surgery for reversal, and we can talk about that in a second. There is some surgical and anesthetic risk compared to no surgical and anesthetic risk. You do need a trained provider. There may be out-of-pocket expenses, given that there may be cost sharing with your insurance company. There's a lack of STI protection, and then there's also the risk of regret. So let's talk about that a little bit. So compared to healthy historical comparison groups, for sexual satisfaction, study has found that 90 vasectomized men had significantly higher scores on erectile function, orgasm, sexual desire, and intercourse satisfaction after having a vasectomy. And so maybe they're not worried about pregnancy anymore, so they can actually enjoy sex more. So sexual satisfaction hasn't been shown to decrease after a vasectomy, and if anything, has been shown to increase. And when they studied the partners of these men, there were no differences for the partners, except maybe in arousal is where they found it. However, with any major life decisions, some people are going to regret their decision. And so 6% of men seek reversal of their vasectomy because they regret their decision after the fact. And there's some factors that are, more likely to make men regret their decision. And so these are things you want to consider when you're counseling your patient. So the age at the time of vasectomy. So if your age was less than 30 or 35, you're more likely to regret it. If you have other children and something happens to them, then you may want to have more children potentially. And it's interesting because it's people that haven't had children are not more likely to regret it. It's people that have had children that are more likely to regret it. If you have a change in your relationship status, you were married happily and then you got divorced and now you have a new partner that wants a baby, that's going to maybe change your mind on how you feel about your vasectomy. If you have issues such as impotence before your procedure and you think that that's going to change after your vasectomy and it doesn't, that could be a reason to regret it. Or if you are one of the men that develop the chronic scrotal pain, you may also regret your decision. So what are our options for fertility after vasectomy? So some men decide to freeze their sperm prior to a vasectomy. And therefore, if they ever decide in the future that they do want to have children, they have frozen sperm, which could be used for IUI or IVF. Some people, and so this is becoming more and more popular with millennials actually, and I was just on a recent webinar where a 20-year-old man who's in medical school had a vasectomy because he was pretty sure he didn't want to have any children and didn't want any accidents while he was in his medical career, did store some sperm just in case he ever changes his mind. But this is kind of a trend that's happening, especially as men are becoming more kind of responsible and involved in reproductive care. But for people that want multiple children after having a vasectomy reversal might be a good option for them. And so that is done by a vasovasotomy, so connecting the tubes back together, or a vasoepididymostomy, where you connect the tube directly to the epididymis. And overall, this procedure is 60% effective. And it depends on different factors of whether it's more effective or less effective. So if there is epididymal blockage, or if there's elevated anti-sperm antibodies, which we'll talk about, or if the man has stopped creating sperm, then it's going to be less effective. Or if there's increased time from the vasectomy, so more than 10 years from your vasectomy is more likely to fail versus if it's been less than 10 years. The other option for fertility is to directly retrieve sperm from the testicle, from the epididymis, and then use it with ICSI to inject into the egg for IVF. And so that is done if kind of all of these potentially don't work, or if you have a limited number of children that you want in the future. And could also be done due to maternal factors, right? So if you're already going to have to defreeze eggs or use donor eggs for the female aspect of it, then maybe you use this method rather than doing a vasectomy reversal. So in terms of anti-sperm antibodies, these are rarely present prior to vasectomy. They can form after disruption of the blood-testes barrier. Few studies correlate the presence or titer with pregnancy outcome after reversal. It's not a deterrent to reversal, but their presence could indicate more of a likelihood of failure. The interstitial fibrosis that's present in the testes happens in 23% of men following a vasectomy, and that can kind of influence fertility rather than the anti-sperm antibody status. So as OBGYNs, what is our role? Several studies actually demonstrate that the decision for a partner to undergo sterilization is usually initiated by the female partner. So us talking to our patients can definitely influence whether the patient has a tubal or the partner has a vasectomy. And patients get this information from their medical professional and their friends. So the more people that get it, that's going to kind of lead to this snowball effect. Also, studies have showed that usually couples choose the method that's believed to be easier, which in this case is really vasectomy. If a physician recommends it, they're more likely to do it, and if there's effective couple communication. Some studies also found that this is kind of what men thought was their contribution to the partnership. And when they've heard favorable outcomes from other men or recommendations from their doctors, they're more likely to listen to it. So when you're counseling your patients, you want to talk to your patients about vasectomy as an alternative to tubal sterilization. You want to inform your patients about this is an in-office procedure. It could be 15 to 30 minutes with local anesthesia, with or without a sedative. It does not produce immediate sterility, so you do have to do a semen analysis. You may have a waiting period depending on insurance. And you want to, provide straight avenues for referral. So it might be your local Planned Parenthood. You might want to find out about that. Maybe a urologist in your department, but have an easy way for patients to get to this person, or else they're going to get lost. So in conclusion, we need to acknowledge that men play an active role in our female patients' health. We want to take the burden off of our patients solely. We want to teach our patients and their partners about their options for male and female methods, and talk to their partners. They trust their partners. We need to help them trust them with birth control as well as engage them in birth control, and learn about these methods so that we can prescribe them and help reduce our patients' unintended pregnancies. I'd like to acknowledge some of the organizations that have helped train me as well as allow me to practice, and I'm happy to take any questions.
Dr. Patel, thank you so much. That was amazing. Such a great talk. I just want to say how funny I think it is. I inject women with lidocaine all day long, and that's just what, we do. And yet when it comes to men, they get this fancy jet injector. That being said, Natalie DiCenzo has her hand up, our finest resident.
Wonderful.
Hi, Dr. Patel.
Hi.
Thank you so much for this lecture. I'm a third year and I'm applying family planning fellowship, so super pumped about this whole topic.
Wonderful.
I'm gonna try to jam in multiple questions. One, did you learn how to do vasectomies during fellowship?
I
Two,
did, yeah.
oh, perfect.
And I
Okay.
specifically asked about it during my interviews, so I would recommend the same.
Okay. Um, Two, I think I saw it said that there is a Medicaid consent form for vasectomy as well, like the same thing for tubal.
It's the same one as tubal. It's the PM 330.
Okay.
And then if
And
there's
then
anything specific for your state.
third question, I know there's not
Yeah.
much time, but can you speak to any of the other like emerging options for male contraception, like the reversible obstruction of the vas deferens and like maybe hormonal contraception for men? Question mark.
Yeah, so there I could do a whole lecture on it. I actually had like 30 more slides. So
I
I'm like, I don't have
know.
time for these, sorry guys. But basically, all of those things are still in the works, meaning that there's nothing like available for patients to actually use. There are current studies that participants can be part of in California, as well as Oregon and a few other places in the country for hormonal contraception. And so basically, when you're talking about hormonal contraception, you want to decrease the amount of sperm in the ejaculate, but then be able to increase it after you stop using it. And so you can't just give testosterone to decrease the amount of sperm because it doesn't work. So you actually need to give a progestin in addition to giving testosterone. So it's like giving a Nexplanon or a Depo shot in addition to testosterone. And so what that does is it tells the brain to lower your FSH. And so therefore spermatogenesis is affected versus just LH, because if your testicles aren't producing the sperm, you still need the men to have their reproductive hormones. And so you give that testosterone back. And so right now there is a testosterone gel in addition to progestin that's being studied in these studies. In terms of other reversible options, there is a non-hormonal pill that is also being studied currently. And then there also is procedures that you're kind of talking about. That's like that mechanical obstruction, like inserting like a dissolvable gel into the vas deferens that obstructs, but then can dissolve over time and then allow for pregnancy in the future. Yep, no problem. Sorry, just trying to be mindful of time. And I'm sorry I ran a little over, didn't have too much time for questions, but I will put my email address in the chat if anybody has anything further that they'd like me to address.
No, we're going to have to end it here. But Dr. Patel, thank you so much for this excellent talk. We really appreciate it.
Thank you. Have a wonderful day, everybody.
Yes, I hope everyone has a productive and fulfilling day. Thank you.